Bismillahirrahmanirrahim. I am Dr. Alishba Rasool, and today I will be presenting Herpes Simplex under the kind supervision of Professor Dr. Saira Afzal. The learning outlines of this presentation are introduction, global burden, clinical presentation, diagnosis, treatment, prevention, complication, recent advances, and MCQs. The learning outcome will be at the end of the presentation, participants would be able to describe the causative agent of the herpes simplex, its clinical presentation, diagnosis, treatment, prevention, and its complications. Introduction. Infection with herpes simplex virus, known as herpes, is common globally. Herpes simplex type 1, oral to oral contact. Oral herpes, also called genital herpes. Herpes simplex type 2, sexually transmitted, causes genital herpes. Both are mostly asymptomatic or unrecognized, but can cause painful blisters or ulcers at the site of infection, ranging from mild to severe. Infection is lifelong and symptoms can recur over many years. Some medications are available to reduce the severity and frequency of symptoms, but they cannot cure the infection. Herpes simplex virus type 1 problem statement. In 2016, last available estimates 3.7 billion people under the age of 50 or 67% of the population had herpes simplex virus 1 infection. Most herpes simplex virus 1 infections are acquired during childhood. People who already have herpes simplex virus 1 are not at the risk of reinfection, but they are still at the risk of acquiring herpes simplex virus 2. Herpes simplex virus 1 signs and symptoms. Oral herpes infection is mostly asymptomatic. Cold sores and herpes labialis. Symptoms can include painful blisters or open sores in or around the mouth. Infected person will often experience a tingling, itching, or burning sensation around their mouth before the appearance of sores. Stage 1. Tingling, itching, or burning. Stage 2. Blister formation. Stage 3. Blister bursts. Stage 4. Scab formation. Stage 5. Healing stage. Herpes simplex virus 2 problem statement. Genital herpes caused by herpes simplex virus 2 affects an estimated 491 million people aged 15 to 49 years worldwide. Genital herpes symptoms, incubation period 5 to 14 days after sexual contact, resolve within 2 to 3 weeks, initial episode. Latent stage, viruses travels to nerves and remains inactive. Recurrent episodes, itching, tingling, or pain in the buttocks, legs, or hips. Prodrome, virus travels through nerves to the skin surface, illness, stress, sunlight, and fatigue, menstrual periods. Genital herpes clinical presentation. Initial episode. First herpes outbreak is the most severe and symptoms tend to be more severe. Blistering or ulcerative lesions on the external genitalia. Systemic episodes, fever, headache, malaise, and myalgia usually in the first 3-4 days. Local, there may be pain, itching, dysuria, vaginal or urethral discharge, and tender inguinal lymphadenopathy. First episode can be primary, in which the person is seronegative or for HSV antibodies occurring after an incubation period of within 5 to 14 days of sexual contact. Initial episodes refer to individuals who have the lesions for the first time but already have antibodies to the herpes simplex virus 2, indicating past asymptomatic acquisition. Although this would be the person's first recognized episode, it would not indicate recent acquisition. Examination findings, grouped or cluster of vesicopustular or ulcerative lesions is observed on the external genitalia, usually used as clinically indicative of genital herpes. Started as papules or vesicles that spread rapidly, multiple small vesicular lesions may coalesce into larger ulcers. Since the ulceration of herpes is shallow, residual scarring from these lesions is uncommon. However, when a person has a typical appearance of a crop of vesicles or gives a history of recurrent ulcers, a presumptive diagnosis of genital herpes can be made and treatment tailored appropriately. Among immunosuppressed individuals, these ulcers may persist and continue to expand laterally and superficially for a considerable period of time if not treated. Recurrent genital herpes tend to be milder than the initial outbreak, tends to have more localized symptoms, itching, recurrent ulcers, and mild pain. Duration of the episode averages between 4 to 5 days, but maybe as long as up to 12 to 15 days. Pregnancy and herpes. Women who have their first outbreak of genital herpes near the time of delivery are at the risk of transmitting herpes to their newborn. Pregnant women with symptoms of genital herpes should inform their healthcare providers. Preventive antiviral therapy with acyclovir is often recommended for women with one or more recurrences during pregnancy. A cesarean delivery is usually recommended in women who experience an outbreak at the time of delivery. Disease, ulcer disease syndrome. The relative prevalence of causative organisms for genital ulcer disease varies considerably in different parts of the world and may change dramatically over time. Currently, however, herpes simplex virus 2 and 1 have become the commonest causative agents of genital ulcer disease in many parts of the world. Other causes presenting with genital ulcer disease are syphilis, trachoma, serotype L1, L3, lymphogranuloma venereum, H. durai, charcoid. Based on an individual's medical history, their signs and symptoms, and the result of the test, differential diagnosis of genital ulcers using clinical judgment have shown to be inaccurate in over 50% of the cases, even by experienced clinicians. Management of the people with genital ulcer disease must be based either on the laboratory-based etiological studies or a syndrome approach guided by periodic evaluation of the causative agents at the local setting. Laboratory diagnosis of genital herpes, molecular testing, PCR of herpes simplex virus DNA from swabs of genital lesions is the most sensitive and specific test. Using a combined herpes simplex virus and T. palladium PCR when available would be of added benefit to implicate or exclude syphilis at the same time. PCR assays have also been developed for herpes simplex virus 1 and herpes simplex virus 2. Culture enables replication of the virus for determining resistance to antiviral therapy and for confirming diagnosis, but results take about 2 to 4 days. Detects the virus in about 50%. The culture is more likely to detect the virus when ulcers are new and open as compared to when they're older and healing. Crusted lesions gives the oldest used more sensitive in individuals experiencing an initial episode than an individual experiencing a recurrent episode. Serology blood tests used when a person has no visible ulcers but has a history of genital ulcers in the past. Having a positive test for these antibodies indicate that the person was infected with the virus at some time in the past. Antibody testing may be negative early during the initial episode infection since antibody formation takes a few weeks. The antibody test remains positive for life. Routine screening for herpes simplex virus 1 or 2 is not recommended. Blood tests may be helpful for couples if one person has a history of genital herpes and the other does not. If the partner has not been infected, then it is important to discuss ways to prevent transmission. Specific antibody tests can distinguish between herpes simplex virus 1 and 2, help to predict the likelihood of future recurrences given that type 2 recurs more frequently than type 1. Treatment of genital herpes. First line options: primary infection, acyclovir 400 mg orally 3 times a day for 10 days, or acyclovir 200 mg orally 5 times a day for 10 days. Recurrent infection, episodic therapy, acyclovir 400 mg orally 3 times a day for 5 days, or acyclovir 800 mg orally twice a day for 5 days, or acyclovir 800 mg 3 times a day for 2 days. Suppressive therapy for recurrent herpes, acyclovir 400 mg orally twice daily, or 500 mg once. Effective substitute, primary infection, valvacyclovir 500 mg twice a day for 10 days, or famiciclovir 50 mg orally 3 times a day for 10 days. Recurrent infection episode, valvacyclovir 500 mg twice daily for 5 days, famiciclovir 250 mg orally twice daily for 5 days. Suppressive therapy for recurrences, famiciclovir 250 mg orally twice daily. For pregnant and breastfeeding women and people younger than 16 years, primary infection, use acyclovir only when the benefit overweights the risk. The dosage is the same as for primary infection in non-pregnancy. Recurrent infection, episodic therapy, acyclovir 400 mg orally 3 times a day for 5 days, or acyclovir 800 mg orally twice daily for 5 days. Acyclovir 800 mg 3 times a day for 2 days. Suppressive therapy for recurrent herpes, acyclovir 400 mg orally twice daily, or varicyclovir 500 mg once. Prevention. Symptoms of oral herpes. Avoid oral contact with others, including oral sex and sharing objects that touch the saliva. Symptoms of genital herpes. Abstain from the sexual activity while experiencing symptoms. Both herpes simplex virus 1 and 2 are most conditions when sores are present, but can also be transmitted when no symptoms are felt or visible. For sexually active people, consistent and correct use of condoms is the best way to prevent genital herpes and other sexually transmitted infections. However, herpes simplex virus infection can still occur through contact with genital or anal areas not covered by the condom. Medical male circumcision can provide lifelong partial protection against herpes simplex virus infection as well as against herpes infection and HPV. People with symptoms suggestive of genital herpes should be offered HIV testing. Recent updates: acyclovir resistance in herpes simplex virus, prevalence and therapeutic alternatives. Herpes simplex viruses, the causative agents of recurrent orofacial and anogenital infection, can cause significant morbidity and mortality in both immunocompetent and immunocompromised individuals. In immunocompromised patients, HSV tend to be more persistent with the chance of dissemination. The nucleoside analog acyclovir has drastically improved the management of HSV infections through acyclovir-resistant strains have been reported in the clinic. We performed a systematic search to summarize the prevalence data. Defining the global prevalence of acyclovir resistant in HSV infections is hampered by the high variability in methodology, patient section, study design, and treatment history. Acyclovir resistant HSV is infrequent in the immunocompetent population, irrespective of treatment history. Exceptions are infections at immune privileged sites such as cornea, where frequent recurrences and extensive acyclovir therapy favor the emergence of acyclovir resistance. High frequencies of acyclovir-resistant HSV infections are reported among immunocompromised, with the highest prevalence seen among the hematopoietic stem cell transplant recipient. All antivirals approved for the treatment of HSV infections have the same target, that is viral DNA polymerase, and cost resistance to different antivirals have been described, complicating the therapy of acyclovir-resistant strains. In this review, we will discuss acyclovir mode of action, mechanisms, and alternate antiviral treatments. Herpes simplex virus and varicella zoster virus infections in the cancer patients. Herpes simplex virus and varicella zoster virus are alpha herpes virus plus established lifelong latent infection in the neuronal ganglia after primary infection. Periodic reactivation of these viruses result in recurrent infections that can have significant impact on patients' quality of life. HSV commonly causes oral and genital mucocutaneous infection, whereas varicella zoster virus is responsible for the varicella and chickenpox. But cancer patients are at particular higher risk of complications, including disseminated and visceral infections due to impaired cell-mediated immunity. While diagnosis of more common HSV and varicella zoster virus infection is frequently clinically based, immunocompromised hosts may have atypical skin presentation and visceral involvement. Thus, diagnostic confirmation among virus-specific tests such as polymerase chain reaction or immunohistochemical staining is crucial in some cases. Oral acyclovir, valacyclovir, and semicyclovir are usually used for mild to moderate infections, and intravenous acyclovir is the drug of choice for severe or disseminated infections. Foscarnet can be used when acyclovir resistance is confirmed or suspected. Pharmaceutical prophylaxis against HSV or varicella zoster virus should be considered in high-risk cancer patients. Currently, there is no commercially available vaccine against herpes simplex virus, but varicella zoster virus vaccines are available to prevent varicella and zoster. Now it's time for our MCQ session. A newly married lady has sort of lesions on her genital area for some days. On history, you revealed that her spouse got infected with genital herpes few months ago. On clinical examination, how will you rule out herpes simplex virus 2 from other diseases causing genital ulceration? A. Pus coming out of from urethral meatus. B. Vesicular ulceration on other parts of body as well as lips, face, and hands. Grouped vesicular lesions on vulva. Painless, firm, round, and small nodule on vagina. E. Painful red-colored bumps in the genital region that become ulcerated.
D.
It's C. A 20-year-old boy contracted genital herpes. Various antiviral drugs are available to treat herpes simplex virus. Which option is not correct regarding the treatment of genital herpes? A. There's no cure for herpes. B. Infection once gives the lifelong immunity. C. Antiviral medication can't prevent outbreaks. D. Antiviral medication can't shorten the outbreaks. E. Antiviral medications can't prevent the transmission. C.
C.
It's A. A 16-year-old girl has grouped vesicular lesions on her lower lip for the first time in her life for 3 days. Along with itching and burning, you suspect that she got infected with cold sore. She is worried about the future of sequelae of this disease. How will you counsel her? A. It progresses to permanent scars in 40% people. B. Keloid is a common complication. C. It can also present exactly the same in your later life again. You can get the lesions or genital area later in your life. E. Vaccination can prevent recurrences.
B.
It's E. Our 20-year-old male has genital ulcers for 3 days who recently visited Thailand. He has positive PCR for HCV-DNA. How will you advise her to take which precautions to control its spread to other individuals? A. Don't share utensils with anyone. B. Wear mask while going to public places. Don't share his personal toothbrush, shaving blades, and scissors with anyone. Don't donate his blood in life. Have protective sex by using condoms.
E.
C.
It's E. Choose the correct option regarding genital herpes in females. Women are infected twice as compared to men. Circumcision in males has no role in preventing transmission. Once contracted, can be cured with medications or vaccination. No risk of transmitting infection once the symptoms are relieved. Recurrent infections tend to be intense and severe.
E.
It's A. A 30-year-old diagnosed case of herpes simplex virus 2 has active genital symptom outbreak of genital herpes. She experienced them 7 times during the past 12 months, which are worse, and she can't accomplish her duties well. What is the best suitable treatment option for her? A. Eradication therapy. B. Episodic therapy. C. Palliative therapy. D. Suppressed therapy. E. Radiation therapy. Anyone would like to answer this?
C.
C.
It's D. A pregnant lady during her 37th week of gestation developed genital herpes for the first time in her life. What medical management you will offer for this lady? A. C-section is preferred. B. Can't prescribe her antiviral treatment now. A course of oral acyclovir for 10 days after delivery. D. Topical acyclovir twice daily for 10 days. E. Wash the genital area twice daily with chlorhexidine will not transmit the infection to newborn.
C.
It's A. A physician advised again oral acyclovir 400 mg thrice daily for 5 days to patient who has symptoms of outbreak for the third time during the last 6 months. What is the advantage of episodic treatment? A. Decrease the duration and severity. Reduce the frequency of outbreaks. Decreases the frequency and duration of recurrences. Reduce the risk of transmitting. E. Given in less dose than suppressive treatment. It's A. Decrease the duration and severity of illness. In settings where laboratory investigations are not available to detect herpes simplex virus 2 infection on the same day, which management strategy is the best one for patient of recurrent vesicular eruptions on the same day? A. Hold the treatment for 1 day to wait for lab reports. B. Continue treatment for both the herpes simplex virus 2 and syphilis. C. Start the antiviral treatment on the same day. D. Treat with topical antiviral initially and then with oral antiviral after the lab report. E. Refer to the facilities where lab reports can be viewed on the same day. Does anyone like to
D.
answer this? It's A. Genital herpes tend to occur again and again if a person once got infected. What is true about recurrent infection? First episode in which the person is seronegative for HSV antibodies occurring after 5 to 14 days of sexual contact. Initial episodes in which person has lesions for the first time but already have antibodies to herpes simplex virus 2. C tend to be more severe than the initial outbreak. D tends to be more systematic symptoms. E blister formation may follow symptoms of itching, tingling, and burning. Anyone?
B.
It's E. This is the key of the MCQs. Thank you everyone for your patient listening. Please like and share our YouTube channel.
Thank you very much, Dr. Alishba. Very nice presentation.
Allah Hafiz.